Good morning. I'm Dr. Duke Majan, CEO and founder of Duke Spine Institute. It is July 31st, 2025. Our first surgery for today is a lower back surgery. This patient has a herniated disc. Elsewhere, he would be offered a fusion, but he didn't want fusion. Smart guy. So he came to Duke Spine Institute for the best alternative to fusion. Fusion is highly invasive back surgery, very risky with complications. Complication rates range from 10% up to 50%. Some surgeons have even higher complication rates. Our patient is asleep, facing down. He's having the safest, most effective treatment in the world. It's endoscopic Duke laser disc repair. We're using the endoscope to find the annular tear and herniation. We're going to use a laser to remove it. All right, let's get started. Now, he presents to us not just with back pain, but also right leg pain. And the only thing I could find besides the herniation, I think he also has some piriformis. But he didn't want to treat the other things that we found. He wanted to focus just on the herniation, which is fine. So we're going to get into the L5-S1 and we're going to fix that herniation. And one thing you guys need to understand is when you're dealing with a herniated disc, there is no surgery in the world that gets rid of 100% of the herniation. The best we can do is around 50 to 80%. That's it there? So why is that? The answer has to do with the approach. You see, how we get to the herniation determines how much we can remove. And there is no approach in the world that you can get 100%. You can go from the front, you can go from the back, you can go from the side. It doesn't matter. No approach gives you 100%. So the best we can do is typically around 50, 60%. Sean? In his case, we'll be lucky to get that much because he's got a big central disc herniation. What does that mean? Nope. What that means is, give me an AP. That means he's got a gigantic herniation going from left to right, but he only has right-sided symptoms. All right, I think we're off on rotation just a little bit. He also has spinous process abnormality at L5. You can see that. He's got probably a spina bifida occulta, spina bifida occulta. Show us the defect in the lamina. Show us the abnormal spinous process. No, it's lower. It's down. It's right. Go left to right now. It's right in there. You're missing some bone. He's got an abnormal spinous process as well. So he was born with an anomaly at the L5-S1 segmentation anomaly from being in utero. We need a better lateral view. I think we're off on the lateral view. So let's try to get that. It's not off much, actually. For the most part, it's looking pretty good. Yeah, your WAG is good, your end plates are good, the pedicles are good, the posterior elements are good. Actually, that looks pretty damn good. All right, so we're talking as we're working here, trying to gain access, to the disc herniation. To do that, we're going transforaminal. What does that mean? We're going through the foramen. What is the foramen, Sean? The foramen is a natural opening in the spine. It's located in the side, John, in the back side. There's a left and a right. And we're going for the right foramen because that's where his leg symptoms are. He's got a radiculopathy on this side. Shot. All right, I think we're there. So I did a little trick with my hand to kind of redirect the needle to get more medial. He's awake. Is he really awake? Yeah, that's awesome. All right. How long has he had back pain for? All right, 5 months. So I assume his leg pain is about the same. This is L5-S1. He's awake? He was worried about being awake.
Can you open your eyes for me?
He's got this big herniation right here. We'll call it H for Hern. All right, do I need another minute?
Yes.
Okay. So let's tell the audience what we're doing here. We got a patient who's under propofol sedation, no tube, so there's no general anesthesia. Propofol can be safer, especially in these short cases, rather than putting a tube down. There's some complications that happen with tubes. We've not had a complication here, but other doctors do. So we like to not use a tube if we can avoid it. We call this sedation, twilight anesthesia. Better for the patient, faster recovery, safer.
Can you open your eyes for me?
Once we
Open your eyes.
verify with the patient this is a painful disc, which we're going to do in just a minute, we're going to get started with the actual Duke laser disc repair. This is endoscopic surgery done from the right side in his case. Sometimes we do it on both sides, sometimes we do it on the left. But in his case, his symptoms are in the right leg, not the left. So we're going to on the right to decompress the nerve root. Now we're not removing any bone or ligament like other surgeons will do when they do a microdiscectomy or laminectomy. And we're going to go and basically put nothing in his spine. No metal, no plastic, no cadaver bone, no biologics, nothing. It's a natural procedure where we go in and just remove the herniation and clean the tear out using a laser. You'll see in just a moment. If you have questions, feel free to type them up. In the meantime, we're going to test the disc and see if it's painful for him. Are you awake?
Doing okay? Open your eyes. Good. We're going to ask you a few questions, all right, my friend?
You having any pain?
Having any back pain right now? You shook his head. You got to see.
All right, well. How bad is that on a scale of 1 to 10?
Give me a number.
How high did that go?
10.
10. Is that where you get your back pain? Is that where you get your back pain normally? Yes? I heard a yes. I heard a grunt yes. So this is concordant. That's great news. What that means is we knew from the MRI this was the problem disc based on the MRI plus where he was showing me his problems were. And I just verified that his back pain was indeed coming from that disc. So that's good news. That means that his back pain should be gone when we're done. If you have questions, feel free to ask them. In the meantime, since we're on the subject of back pain, Henry, let's share with the audience while we get started here and get our scope in. What are the main causes of back pain in somebody? I'm Dr. R. Duke Machen with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. Welcome back. You see from our video, there are 30 things that cause back pain, chronic back pain, which is back pain lasting more than 2 weeks. Now, chronic back pain is not going to go away on its own. It may get better for a short time, but it's always coming back. So people who live with chronic back pain know this. All right. But from the video, you can see the number one cause of chronic back pain is, it's okay, they can do it as long as they need to see. The number one cause of chronic back pain is a disc injury. This patient has a disc injury. We're looking at the disc injury right now. What we should be seeing is pure white, just white. We're not seeing white. We're seeing a torn annulus and a herniation. The blue stuff is the herniated disc. It's the nucleus that's squeezed out of the center of the disc, which is way down here, and it's squeezed out into a tear in the back wall of the disc. Now, once it comes out through the back of the disc, it can actually pinch the nerve root and cause weakness, numbness, and tingling in the leg. It can also irritate the nerve root through a process called inflammation and cause sciatic pain down the leg. This patient has weakness, numbness, and sciatica, all due to this herniation right here. Now, his herniation is on both sides, left and right, but he doesn't have any symptoms on the left, so I didn't recommend surgery on the left because it's unnecessary. We can't make no symptoms any better than no symptoms. No matter how good the surgeon is, you can't do better than no symptoms. So why take the risk and putting the patient through another procedure on the other side if you can't benefit? The laser fiber is 0.5 millimeter, 0.5 millimeters wide. That's the glass. That gives you a perspective on how zoomed in we are with the endoscope. That's how amazing this tool is. It gives the surgeon the best view they could possibly get. Better than a microscope, better than no microscope is the endoscope. So we have the best view. We're able to see sub-millimeter structures below a millimeter. If you're using just your eyes, which is what 90% of surgeons do, their eyes can only see about maybe a millimeter or 2 millimeters. And a microscope, you can see about a millimeter. And with an endoscope, that fiber is 0.5 millimeter. Sorry, that fiber is 1 millimeter. So we're able to see about 1/10 of that, maybe 1/20th of that. So much better resolution with the endoscope than any other tool. So you're going to get more specificity, more sensitivity with endoscopic spine surgery by being able to see things better than any other surgery technique out there. That's why some neurosurgeons are just starting to adopt endoscopic surgery. I went to a meeting in Boston recently for the American Association of Neurological Surgeons, and their leading endoscopic spine surgeons in the mainstream university hospitals. They've been doing endoscopic surgery for a few years, nothing compared to my 20 years of endoscopic surgery, where I've been teaching online for the last 10. This is the herniation here, and we're taking it apart little by little. There's no way to get it all out, but you can see it's scarred down to the annulus, scarred from inflammation causing scar tissue. And that's what I'm using the laser to remove. There's no way to just reach in and grab it and take it out. You have to remove it a little bit at a time. Herniations never come out as just one big piece and you're done. There's always small pieces, and they're always stuck down to the wall of the disc, and they require a release. That's what the laser is for. That's what the laser's primary job is to free up this herniation from the wall of the disc so you can get it out. I'm going to put the grabbers in a moment, but this is what we're doing. It's probably going to take me another 10 minutes, Dr. Berndes. And again, we'll never get 100% of the herniation. I tell every patient that. Don't expect to get an MRI and see the herniation completely gone. It's not going to be. There's no way to get rid of 100% of an L5-S1 disc herniation. You want to get rid of enough of it so that the symptoms go away. All right, any questions?
Yes, we have a good amount of questions. This first one is coming from Faisal on Facebook.
All right, before I take Faisal's question, thank you, Faisal. I just want to point out, you guys see the orange color right there? That is calcium inside the scar tissue, inside the annular tear. Remember, the annulus is a normal structure. It's the wall of the disc. It's there to keep the blue stuff stay in the middle. The blue stuff is called the nucleus pulposus. The nucleus pulposus is normally white. There's a piece of herniation right there. You guys see that? That's a nice one. It's about a centimeter. So the nucleus is normally white. It never should be blue. The only reason it's staining blue is because it's degenerated. If this patient did not have a herniated disc and I injected blue dye into their disc, the same Duke spine blue dye, it would not stain blue. It would stay, the nucleus would stay white. The only reason it colors blue is because it is herniated and degenerating. What does that mean? It means that it's got acidic characteristics. That's ACIDIC, not Hasidic, not like a Hasidic Jew. It's acidic, ACIDIC. That was supposed to be a joke. I didn't get enough laughing in the operating room. You guys are all fired. All right, we'll take the questions.
First question coming from Faisal on Facebook, asking, does this patient have symptoms of Cauda equina syndrome, CES? Thank you.
Cauda equina syndrome.
Yeah.
The answer is no, he does not. Though when you look at his MRI, you think, wow, he should, right? That's a big herniation. But no, he does not. Cauda equina syndrome is basically Cauda equina. Cauda is tail, equina is horse, horse's tail. Remember the old anatomists that used to dissect human bodies back in the 1800s? They would describe things they saw based on foods and based on things that were important to everyday life, like horses. So when they opened up the spine and they saw all the nerve roots in there, they called it the cauda equina. It's basically the horse's tail, okay? It's a bunch of nerve roots at the bottom of the spine. So cauda equina syndrome is basically a syndrome where patients experience symptoms related to compression of multiple nerve roots on both sides. He does not have that. He only had symptoms on the right side. And it was in one nerve root. This is another piece of herniation here, laterally. Any questions?
Yes, this next question is coming from Renee on YouTube,
Hi, Renee.
asking, where is the surgery?
Well, I don't know what you mean by that, but we're in Florida. We're in a place called Melbourne, Florida, just outside of Orlando. And that's where Duke Spine Institute is located. As far as what body part are we operating, we're operating on the disc. He has a herniated disc at L5-S1. So this is in his lower back. By the way, our patient is young. We talk about age of patients having back problems. He's around mid-20s. I can't give you his exact age, but he's in his mid-20s. And he's here with his mom, who's providing him with great support. What a great mother he has to bring him here. And they're from Michigan. They traveled all the way to Florida from Michigan to have his back fixed with the Duke laser disc repair, because we're the only ones in the country that offer this endoscopic treatment. The Duke laser disc repair has been performed for 20 years. We've done over 2,650 surgeries with this endoscopic Duke laser disc repair you're watching right now. As a matter of fact, later today we have a treat for you. We have a thoracic Duke laser disc repair, an extremely rare situation. The most common symptomatic herniated disc is lower back, lumbar. The second is cervical or neck. The third is thoracic. But thoracic symptomatic herniated discs are very rare. They account for about 1% of all symptomatic disc herniations. But we have a nurse who's coming here to have her thoracic disc fixed this afternoon. And you guys can watch that if you come back for our next surgery after this one. Again, a nurse coming to Duke Spine to have her herniated disc fixed by Dr. Duke Majan. Smart nurse. We love nurses here at Duke Spine. Right, Luis? What it's called a reherniation is basically the disc. What it's called a reherniation is basically the disc has to heal. The annulus wall has to seal off. It will seal, but it takes about 9 months to do that, okay, on average. And that's because the disc itself has very little blood supply and it takes a long time to heal. So during that first 9 months, we give our patients very strict, oh, look at that herniation. Oh yeah. We give our patients very strict restrictions. No contact sports, no heavy lifting, and that keeps it from reherniating. So basically the patient has to help and actively be involved in their own recovery. I need them to basically avoid any type of activity that would cause a reherniation. Now some people think that this stuff is watery. It's not. It's actually pretty thick and it's cohesive. It stays together. So really, my job is to get out as much of these pieces as I can right now, and then what's left is healthy nucleus and it stays together cohesively, and just patient has to be careful, thank you Luis, not to push out more pieces. Does that make sense? I hope that makes sense to you. It's kind of like, I mean, there's lots of things in life where the patient has to be, participating actively in their recovery, right? We ask people to do all kinds of stuff after surgery, to exercise, to eat healthy, to avoid smoking, to avoid use of nicotine or other products that could impede healing. So it's not unusual for patients to be actively involved in their own recovery. We expect our patients to be actively involved. All right, I'm getting out little pieces of this herniation at a time. I'm not really getting a gigantic piece. It's just little pieces. But good news is it is coming slowly. We're getting some good results here. Any other questions?
Yes, we have a question coming from Faisal once more on Facebook, asking, Doctor, can you explain to us what's the difference between a discogram and a nerve block procedure for diagnosis purposes? I realized that in the UK, they offer nerve block or steroid injection for diagnosis purposes and pain relief, which never works, rather than a discogram. Why is that?
Well, first of all, nerve block and discogram are two different things. Nerve block is a therapeutic treatment usually. It's a therapy. It's to make you feel better. A discogram is not to make you feel better. It's to confirm that the disc is indeed the source of pain that you're having in your back or neck. So the discogram is a diagnostic test. Nerve block is a therapeutic to give you relief. But all nerve blocks, such as epidurals, they all wear off, okay? Now, some people do what are called selective nerve root blocks, which I don't agree with. I think it's just a unnecessary treatment. It's just not needed. There's a lot that's done in medicine that, in my opinion, is unnecessary and doesn't help patients, okay? There's a lot, and everyone else will agree eventually when they understand as much as I do about the spine and back pain. There's a lot of doctors out there recommending treatments that don't work, and they're recommending treatments that make the patients have to keep coming back over and over again. That's for one purpose, to make money on the patient and their insurance. It's my belief that those treatments should be basically thrown in the garbage, okay? There is now permanent cure to back pain and neck pain. And you can find those at Duke Spine Institute. We broadcast them every week. Obviously thoracic pain as well. And people should stop getting shots. They should stop getting stimulators. They should stop getting fusions. They should stop getting artificial discs, stop getting laminectomy. All those procedures are, for the most part, unnecessary. I'm not saying 100%, but I'm saying about 95% of those procedures that are recommended to patients around the world, those microdiscectomy, laminectomy, fusion, artificial discs, mild procedure, basovertebral nerve ablation, and fusion. Those are some examples. Epidural steroid injection, radiofrequency ablation. All those treatments are now can be replaced by the Duke laser disc repair and the Duke plasma rhizotomy procedures. And our procedures are permanent pain relief. They're not temporary, they're permanent. Whereas all those other treatments are temporary, at best temporary. Most of the time they don't even work to eliminate pain. But sometimes they do, and when they do, it's temporary. So basically what we're seeing is all these unnecessary treatments and tests being recommended to patients around the world that someday are going to be gone because doctors are going to realize they're doing these things and it's not really helping the patients. And insurance companies are going to realize that too, and they're going to stop paying for them. My opinion, they should stop paying for them now. There's another piece of herniation. Again, we're not getting big pieces, we're getting a lot of little pieces. And it's not unique to him. This is pretty much every patient I operate on. They have this herniation that just is a bunch of small pieces scarred in there. I've got 5 minutes, Dr. Berndes, 5 minutes. This is just really scarred down. It's just obviously taking a while to get it as much out as I can. Any questions?
Yes, we have a question coming from, or a comment at least, coming from Frank on YouTube.
Oh, hi, Frank.
Saying, "Hi, Dr. Duke. Sorry, I haven't been watching too much lately because I'm still in extreme pain in my lower back into my left leg. Sometimes the pain is so extreme I feel like I'm going insane."
Yeah. Well, Frank, come in and get treatment. That's what I can say. We can help you. We want to help you. Come to Duke Spine so we can help you out. All right, I'm feeling a lot of pieces. Look, there's another piece of herniation. That's a good one. I've literally taken out a lot of pieces now, and when I put my grabber inside this tear, I can feel more herniation pieces. So I'm going to keep going until I get them all. Now, I'm not going to get 100%. We've already talked about that. You cannot remove 100% of the disc herniation. It's just not possible.
We have another question
Sure.
coming from Rick on YouTube, asking, would you mind explaining acronitis and how a serious of a problem it is?
Yeah, sure. Arachnoiditis. It comes usually from doctors sticking needles in people's backs or spines and injecting medicine. When the medicine causes an inflammatory response, the nerve roots will, the arachnoid around the nerve roots or membrane around the nerve roots will become inflamed, and that'll cause scarring of the nerve roots together. That's arachnoiditis. Inflammation causing scarring of the nerve roots in your lower back to scar together. Arachnoiditis only causes burning in the legs. It doesn't cause any other symptom. So if you have other symptoms, it's not coming from arachnoiditis. One of the mistakes people make is they think all their symptoms, like back pain, weakness, are all due to arachnoiditis. My experience with arachnoiditis is that arachnoiditis causes burning in the legs. So if you have back pain, it can probably be fixed. You just need to do an MRI review at Duke Spine. Our MRI reviews are free, and they offer people an opportunity to get a diagnosis. What's causing their symptoms? I'm almost done here. I don't feel much more. There is one piece here that I'm getting. It's a good sized piece. Wow, look at the size of this one. This is a biggie, guys. Oh my God, it's too big. Oh, too big to fit out of the tube. It's so stuck down from scar tissue. Let's see if we can't get it. Oh yeah, it's breaking up into pieces. You guys see this thing?
Yes, we did.
That's a piece of herniation right there. That's the biggest piece we've got so far. My God. It's like trying to take a shark out with a fishing pole. Whoa, there it is. Look at this, Henry. Look at this. Holy moly, can you see the size of this thing?
Yes, we can.
There it is. That's the big one, guys. So we got a bunch of little ones, and we got one ginormous Godzilla piece. Look at that, 4 centimeters long. It's like a caterpillar. See that, Berndes? Pretty impressive, huh? All right, we should be done in just another 2 minutes. Good, he's doing great. By the way, our next case is going in room 2, right?
I think he requested to do it here, so
Oh.
we're gonna process payment.
Why are we doing everything here? You guys don't want to save
no,
time?
We're gonna go in the room.
He's not patient.
Oh,
just-
okay.
Just a patient.
Which patient? Thoracic?
Let's do the body weight.
Oh.
Next patient.
Oh yeah, yeah, of course. Still, we got another good-sized chunk right here. I'm going to try to get out. All right, so our next patient's going to be in here, and then the one after will be in here.
Yes, correct. And then we can go.
Fine. Absolutely. So we're just talking about the next case. The next case is a,
It's gonna be a DPR, the SI joint.
that's another big piece right there. Guys, I'm getting more herniation than I expected. This is great. So the next case is a DPR what? SI? All right. All right.
We had a little trouble with respiratory fatigue on this,
Uh-huh, no problem. Any questions, Henry?
Yes.
This should be it right here. Oh, again, it broke. You guys see that? It just ripped.
Yes, we do.
The problem is the herniations are stuck down to the disc because of all the scar tissue holding it down. The reason there's scar tissue is inflammation. Remember, these herniations cause the disc to become inflamed, and that inflammation causes scar tissue. Oh. Ah. Yeah, man. It just keeps ripping as I'm just about to get that thing out. This is another big one, though. We're going to get this out, and we should be done. All right. Sorry, guys. But I think he's going to be really happy with these results. Let's hope. Now, people ask me sometimes, how come I have numbness after surgery? Numbness, weakness, and tingling. Oh, that's a big one. That's a big one. There it is. Another giant. Weakness, there it is. That's, look at that, guys. Look at that, Henry. You see that?
Yes, we do.
All that taken out from a 7 millimeter tube, guys. This is amazing. All right, why do people have weakness and numbness that lasts after the surgery? The answer is nerves. Just because we've got the pressure off the nerves by removing the herniation doesn't mean the nerve is healed right away. It takes time for those nerves to heal. I don't feel any more herniation. So I'm going to clean that last bit up with the laser, and then we should be done. So I'll take questions right now.
We have a question coming from Frank once more on YouTube,
Sure.
saying, "I was there, Dr. Duke. Don't you remember you did surgery? I'm still having that pain in my SI joint. I guess that's what you told me last time."
Yeah. But what I'm saying, Frank, is come get it fixed. Come get it fixed. Whatever is wrong, come in and get it fixed.
And then a follow-up comment, he asking, "You need the Grabzilla."
We don't need the Grabzilla. Nope, we're pretty much done here. I'm just going to clean this last bit up, and we should be done.
And then we have a comment coming from Faisal once more on Facebook, saying, "Doctor, it was great to see your podcasts. What was interesting was to see Henry's face on the screen finally. He does look indeed different than he does speaking." Thank you.
Yeah. I think you're complimenting him.
I'll take that as a compliment. Thank you, Faisal.
I think Henry's blushing right now. All right. Any other questions?
At this moment, no current questions.
Let's show the audience how these herniated discs cause so much pain for patients.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Okay, welcome back. We've shown you now how a herniated disc can be so painful, causing back pain. Let's show you how we fix it. And then we're going to be done, because this is it. We're pretty much finished. I don't feel any more pieces of herniation. I think we're good at this point. I can't get anything else out. I'm pretty happy with that.
Sitting on, please.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. You see that we use the laser to clean the annular tear and get the herniation out of the tear so it can heal. Look at all these pieces of herniation. You got a couple of biggies, a lot of small pieces. We got some more over there that's going to the pathologist, but this is how it typically is. You see lots of small ones. There's probably about 100 small pieces, 2 big ones. Most herniations are not just one big piece of disc, it's many. He should do fantastic. Remember, we tested the disc for back pain and he had a 10 out of 10 pain. All right, Any other questions?
At this moment, no current questions.
All right, very good. Thanks for joining us. We are done, and we'll be back with our next surgery in about